Good evening. I'm Alan Matisow, Associate Director of the Baker Institute, and I'm very pleased to welcome this crowd tonight to this event. The event is actually part of a series of events that the Baker Institute is hosting during this year, events we're calling Campaign 2008. The purpose of the series is to probe beyond the sound bites of the politicians and to promote serious discussion of the issues that have emerged and will emerge, we think, during this campaign year. We're going to have a series of 5 panels, beginning with tonight's panel on health policy. The second panel, and if you have your calendars handy, I get them out for this one. The second panel will occur on April the 24th, which is a Thursday. The topic is tax policy, and the participants are Austin Goolsbee of the University of Chicago and an economic advisor to Senator Barack Obama, and Doug Holtz-Aiken, a senior fellow at the Peterson Institute and senior policy advisor to Senator John McCain. When this was arranged, we had no idea who the candidates were, but there may be something prophetic in this panel. In the fall, we'll have 3 other events. They will be on science policy, foreign policy, and energy policy. We have invited very prominent members of both parties. Their views will be divergent. The discussions will occur in the very heat of the campaign, and we think they will be very important discussions. So in the near future, I expect we'll be able to publish the details of these events, and as is obvious, everybody here is interested in public policy, and I think that you will wish to attend all 4 of the events that will follow this one. It seems entirely appropriate tonight that we kick off our series with health policy, because it has emerged as perhaps the most important issue of the campaign to date. The scholar who put together tonight's panel is Dr. Vivian Ho, who is a professor at the Baylor College of Medicine and also a professor of economics in the Rice Department of Economics. Professor Ho is a health policy economist, and she has received funding from the Agency for Healthcare Quality and Research, the American Cancer Society, the National Cancer Institute, and the National Heart, Lung, and Blood Institute. She is a prolific scholar. She publishes in leading journals, and it is Professor Ho who invited tonight's guests. She will moderate the program, and she will do the introduction. So welcome, Professor Ho.
Thank you, Alan, for that introduction. I think the size of this crowd, as Alan said, indicates the level of interest for the primaries next Tuesday, and also, as Alan mentioned, the importance of healthcare policy within the election and within the interest of the general public in this nation. And it is, a great part of the reason why the Baker Institute established the Health Policy Forum last year. And the forum is a new initiative on the part of the Baker Institute to not only track different proposals for healthcare reform, and you saw some of our slides rotating through prior to the talk, and those will be up on our website, tracking the differences between the current presidential candidates in terms of their healthcare policy reforms. But we're also going to be providing some objective analysis of proposals put forth by many other different organizations, such as other think tanks, different employer groups which are proposing different types of healthcare reform, and of course state reforms, because these are all going to mix together and have an influence on our new healthcare policy, whoever is going to be the new president. Another initiative of the Health Policy Forum is to focus on particular health care challenges within Texas, And as you all know, we have bigger problems than everywhere else. We have a 25% rate of uninsured, and we have higher costs on average of health care in this state relative to many of the other states in the country. So look for new initiatives on part of the Health Policy Forum to be looking at those issues in the future. We couldn't have done this type of work without the support of different sponsors, so we're particularly grateful to the Sid Richardson Foundation and to Humana, and as well as a sponsor, and to the MD Anderson Cancer Center. And also we're delighted we had a new member join just yesterday, which is the St. Luke's Episcopal Hospital. And so with that, I'm going to move on to introducing our two speakers here. And as you will see, you've been given a formal program, and in that program there are official biographies which describe our two speakers, Karen Davis from the Commonwealth Fund tonight, and Jonathan Skinner, who is a professor at Dartmouth University. I won't go through the process of reading you those biographies, which you can review for yourselves, but they do illustrate the extensive professional accomplishments of these two individuals, both in terms of their academic contributions to research in terms of health economics and health policy, but also in terms of their government service and public service with respect to health policy. What I'd like to do is instead give you a little bit of a personal introduction of how I sort of encountered these two individuals. So I'll just introduce Karen Davis now because she's going to be speaking first. Dr. Karen Davis is actually a Rice graduate, so she did do her PhD in economics here, and she was also an assistant professor here on the faculty as well. Now, despite that, Karen and I didn't actually meet until today. We've corresponded and knew of each other's research, but we didn't actually have a chance to meet face to face. That being said, I actually became aware of Dr. Davis's work right when I started my first job back in 1992, and I was interested in doing research on differences in medical use, medical expenditures by income class. And I went and did a search through the literature, and amazingly enough, the only person who had published on this type of research in the economics literature was Karen Davis. So she has been working on this particular issue before it became the hot topic, before it became something that was neat to work on because it was funded by the NIH, and has been an important contributor to this field. And as you'll see tonight, she has some very insightful things to say. So with that, the format will be 20 minutes for each speaker so that we have plenty of time left over for comments and questions after. But with that, I'm going to hand it over to Karen.
Thank you, Vivian, for that lovely introduction and also for the opportunity to be here. I spent 10 wonderful years at Rice, so it's always nice to come back home. And I also had an opportunity to attend commencement exercises in 1991 when Secretary James Baker was the commencement speaker and talking about his vision for this particular institute. But of course what I remember most is the story he told of Captain James Baker and his pivotal role in the founding of Rice University. It's a great honor to talk at this particular moment in time about how the U.S. might move toward a high-performance health system and what it will really take for a president to not only address the issues we have of growing numbers of uninsured, but how to reform our healthcare system to enhance the value that we get for the money that we spend on healthcare. Feeling that this is an urgent problem, the Board of Directors of the Commonwealth Fund 2 years ago established a commission on a high-performance health system. It consists of 19 experts from all different kinds of backgrounds across the U.S., chaired by Dr. James Mongan, who heads the Massachusetts General Brigham Partners healthcare system in Boston. And we said, all we want is for you to do the impossible, to find out how we can simultaneously have better access, improved quality, and greater efficiency. Many people said you can have 2 out of 3, you can't have all 3. We said, the Commission, we want ideas, we want solutions. The first thing the Commission did was to really put together, take stock of how the U.S. healthcare system is performing Counseling and looked at 37 different indicators of performance on the key dimensions of healthy lives, access to care, quality, efficiency, equity, and found that the U.S. scores 66 out of a possible 100, where 100 was set at not what is ideal, but what has been achieved somewhere in the U.S. or in some country on these various indicators. What is the average for the U.S. relative to what is achievable? That was published in a journal, Health Affairs, in September of 2006. In June of 2007, we followed it up with a scorecard on the performance of individual states. I don't think Vivian mentioned that I come from Oklahoma, and 2007 was the centennial for Oklahoma, so I was quite chagrined that Oklahoma made it into absolutely bottom place, so that Texas did not have that honor. But as Vivian said, there are serious problems here in the Texas healthcare system. In fact, it is in bottom place on the problem of the uninsured. She mentioned 25% are uninsured. If you just look at adults, 30% of adults are uninsured in Texas, compared with Minnesota, where 11% of adults are uninsured. In fact, of all states, just did as well as the best states on various indicators of performance. We would cut the uninsured rate in half, save about 100,000 lives, as well as billions of dollars in our healthcare system. So the Commission has said we need to take a broad approach, not just focus on how we cover people, but really how we improve overall performance, get better health care for people, get better outcomes, and do so by getting more for the money that we're spending or improving efficiency in the system. The Commission issued a report in November of 2007 called An Ambitious Agenda for the Next President, and said to really move the nation onto a path of high performance, we really need a five-pronged strategy. We need, most importantly, to expand health insurance for all. But we need to really realign the financial incentives in our healthcare system that are currently sending the wrong price signals to the market. We need to change the way we organize healthcare. It may be surprising to you when you see the medical center across the street, to realize that most of American medicine is still a cottage industry, solo practice physicians, a very fragmented healthcare system that does not lend itself to modern methods of communication and using modern tools. We need to narrow variations and raise everybody up to the achievable standards. That's going to take investment in our infrastructure, particularly information technology, but identifying and spreading best practices. And then finally, we are going to need national leadership, and we're going to need all parts of the healthcare sector, public and private, pulling together to really transform performance. Starting with affordable health insurance for all, the Commission again put out a report called A Roadmap to Health Insurance, Principles for Reform, and looked at three different strategies. The first strategy is to provide people with tax incentives to purchase health insurance in the individual health insurance market. The second is to build on our current private-public system and expand that system of group insurance with shared responsibility across federal, state, governments, employers, and household. Or a third strategy is sometimes called the single-payer strategy, covering everybody under public insurance. There was a presidential candidate, Congressman Kucinich, who had advocated that, has since dropped out of the campaign, but in fact Senator McCain has put forward a strategy very much along the line of tax incentives. Both Senator Obama and Senator Clinton are talking about mixed public-private strategies with shared financial responsibility. You see some of the advantages and disadvantages of those strategies. The mixed public-private is geared for covering everyone, setting a minimum benefit floor, making sure that any out-of-pocket expenses are affordable, that it is easy to enroll, that you have choice, as does the strategy of giving people tax incentives to purchase coverage in the individual market. One advantage of building on group coverage is that it tends to pool health risks more broadly. One disadvantage of the individual health insurance market is in some states it's particularly difficult to get coverage if you have prior health problems, pre-existing conditions. Another issue is not dislocating coverage that people have. I think that was one of the reasons for the failure in 1993, that people didn't want to switch to something brand new if they had something that now worked. Administrative simplicity, and obviously how well does it work to improve quality and efficiency. Just to illustrate a little bit this whole notion of mixed public-private strategy, the basic way most Americans get health insurance is from their employers. About 160 million Americans get health insurance through their employers. Under this particular strategy, that would be expanded by covering, for example, young adults under their parents' policies and requiring all employers to make some contribution toward health coverage, which would induce a few more to cover the uninsured. The second strategy is building on the type of system that covers members of Congress, called the Federal Employees Health Benefits Plan. Massachusetts had a similar kind of initiative, which is called a connector, but some way of setting up an entity that offers a variety of private health insurance plans to small businesses, individuals, people who can't otherwise get coverage. A third strategy is expanding the Medicaid program or the state children's health insurance program for low-income people to cover more low-income adults. And a final strategy is to expand coverage for Medicare, particularly for older adults who often have difficulty buying coverage in the individual market. Both Senator Clinton and Senator Obama have an insurance connector based upon what members of Congress have, but they would also provide a Medicare-like option to people to purchase. Well, let's turn then to what are some of the ideas being advanced to deal with changing financial incentives. Again, our Commission on a High-Performance Health System said lots of candidates are waving their arms and saying we believe in prevention, we believe in controlling chronic conditions, we want to improve information technology, but nobody really has a detailed, concrete proposal with cost estimates of would that really and truly save money. And so the Commission came up with 15 different ways in which total health system spending could be saved over 10 years, contracted with an independent group called the Lewin Group to do estimates about how much it would save the total health system, how much it would save the federal government, state government, employers, and households. And things like investing in information technology, again, a very specific proposal that starts by imposing a fee of 1% of insurance premiums, 1% of Medicare outlays, giving that to states to accelerate the adoption of information technology. It actually takes 7 years before there begins to be net savings to the health system, but then takes off after that point. So $88 billion in savings after 10 years. Another strategy that a number of candidates have supported, establishing a center on medical effectiveness and healthcare decision making. But again, to get savings, it has to have teeth. So this linked not only finding out which drugs, devices, procedures are most effective, but would require patients to pay extra if they want a drug that's more expensive but no more effective than an alternative. So there are a number of different strategies. I won't go into all of them, but at least begin to get people talking and thinking about something other than just arm waving and ways in which we really could generate savings. If you combine a number of those options, particularly those that invest in information technology, reform the way that hospitals, physicians, and other providers are paid, increase taxes on tobacco and sugared soft drinks, and put that money into obesity prevention or tobacco reduction strategies, Over 10 years, the estimate, again coming from the Lewin Group, is that there would be savings of $1.5 trillion over that 10-year period, even if combined with a universal health insurance coverage along the mixed public-private strategy that I outlined. So $1.5 trillion may seem like a lot of money. Really, all it does is slow down the rate of increase. If we do nothing, we will go from spending 16% of the gross domestic product on health care to 20% in 10 years. This brings it down to about 18.5% in 10 years, but certainly it's not holding constant outlays as a percent of our gross domestic product. But $1.5 trillion is significant. It also would yield significant federal government savings and would offset some, not all, but significant amount of the incremental federal costs of providing subsidies to low-income uninsured people to purchase coverage. Without reforms, just covering everybody would initially cost the federal budget about $80 billion. In 10 years, it would be, in that year alone, $205 billion. If you did that combination of reforms that I illustrated on the previous chart, that incremental federal budget cost could be reduced in the 10th year to about $10 billion. So it's actually a pretty optimistic study, saying that if we start now and are serious about reforming both the organization of care, the way we pay for care, really invest in effective health promotion activities, transparent information technology, we can achieve savings over time sufficient to offset much of the cost of expanding coverage. But we've got to change the way, all of these are going to be difficult to do. There's a lot of evidence that larger systems of care, large physician group practices, integrated delivery systems yield significant savings. There's less waste, less duplication, there's better communication among providers. Particularly if people are enrolled in what are now called patient-centered medical homes. All of us think we've got a regular doctor. And I don't know what it's like now in Houston, but in New York, it doesn't mean you can get in to see your doctor just because you have a doctor, or that you can get a phone call answered. And so the concept of a patient-centered medical home is that you can get same-day appointments, that you can get care on nights and weekends, that somebody will actually help you navigate the healthcare system if you've got a serious problem. The Commonwealth Fund has supported the National Committee for Quality Assurance to set standards on what constitutes a patient-centered medical home, what must you do to qualify, and most recently a private sector effort called Bridges to Excellence, where the major corporations, General Electric, Ford, and others, have said they will pay physician practices $125 a person a year if they meet the National Committee for Quality Assurance standards. Now, they're not doing that to be charitable. They're doing that because there's evidence that if you have that type of medical care accessible to you, it will reduce use of emergency rooms, it will reduce preventable hospitalizations from things like asthma, diabetes that get out of control. To really, though, improve performance, it's going to take more than insurance coverage, aligning financial incentives, and having a medical home. It means having a modern system. It means having data on quality and cost so that you know what the 5-year survival rates are for cancer at MD Anderson versus Sloan Kettering versus anywhere else. In the U.S., you know what the cost of care is depending upon where you go. It means identifying why certain places have high performance on both quality and cost, try to spread those best practices, investing in IT and comparative effectiveness. We all believe that the U.S. is a leader in technology, and we are in many fields. We just don't happen to be a leader on health information technology. The Commonwealth Fund every year funds international surveys, now in about 7 countries, including the Netherlands, New Zealand, the UK, Australia, Germany, the US, and Canada. And we and Canada are at the lowest in the proportion of our primary care physicians who actually use electronic medical records. My favorite country in this regard is Denmark. I was invited to evaluate the Danish health system back in 1999. They now have totally electronic physician offices. They do all of their prescribing electronically. They order their lab tests. And the patient can go on the internet and see all of this information. If they show up in an emergency room or an off-hours clinic, the doctor can pull up all the medications that they're on. The pharmacy tells this Medcom system when they fill a prescription. Most doctors don't know if you fill a prescription or if you've let it lapse. So it's a fantastic. And the other thing I love about this Danish system, they run this for 5.4 million Danes for $3 million a year. It's not a hugely expensive system. It was developed by IBM, I'm sure, for more than that. But to run that is basically about 40 cents to 60 cents a person. Finally, we need accountable leadership. Some people are starting to talk about establishing a Federal Reserve for health. When you have every private insurance company with a different set of rules for doctors and hospitals, you wind up with huge administrative costs. Now everyone is demanding that they meet quality standards, but they're all using different quality metrics. We need some way in which we will pool information across public programs like Medicare and Medicaid and private insurers, set goals, and work in concert toward those. So what does this mean about the presidential debate? As I said, the candidates are all talking about this. They are all putting proposals on the table. I think that's very healthy. Senator Clinton would require everybody to have coverage. Senator Obama would require parents to have coverage for children. Senator McCain said it should be a choice. Senator Obama and Clinton both require employers to contribute part of the premium. They don't say exactly what percent of the premium, but some percent of payroll toward premiums. Senator McCain does not. Senator Clinton Obama would expand the low-income children's program. Senator McCain has not committed to that. Senator Clinton, Senator Obama would regulate private insurance markets and say at least 85% of the premium has to go for medical care. Senator McCain uses a competitive approach, including letting people buy insurance in any state. Again, Senator Clinton, Senator Obama would help people pay their premiums on a sliding scale. Senator McCain, and I think this is a very important feature, has a refundable tax credit that would give everybody $2,500 to go buy health insurance on their own. But there are more similarities on the way that they would try to promote quality and efficiency than you might think. They all support health information technology, making information on quality and cost available. P for P stands for pay for performance, really giving incentives to hospitals and physicians to reach high levels of quality care, and a variety of other measures. So sometimes you have to look closely to see the differences. They do agree that something should be done on coverage. We should move forward with getting to a modern healthcare system. McCain, Obama, Clinton all support pay for performance and comparative effectiveness. Where they divide has to do with this issue of whether everybody should have coverage, who should pay for it, in particular whether employers should pay and contribute toward it, and then the role of private insurance and the role of private markets. So in sum, we're on the wrong path in this nation. Costs will exceed 20% of the gross domestic product if we continue on our current course. We've had a major growth in the numbers of uninsured over the last 7 years. We will wind up not only with low-income people affected by difficulty paying for bills, but also a squeeze on the middle class. with more people either uninsured or having inadequate insurance that leaves them unprotected against high medical bills. We certainly have the expertise and the resources to do much better. We know what can be done. We have achievable benchmarks. What's really required is the leadership that will achieve consensus, and that means that everybody in the room and all Americans really get educated, and a president and Congress that lead and bring us all together to promote the common good. So many thanks for your attention, and also many thanks to my colleagues at the Commonwealth Fund.
Thank you, Dr. Davis, for some very sobering information, but also some promising solutions. We're going to hold questions for Dr. Davis until after Dr. Skinner has spoken, and then we'll be inviting comments and questions from the audience after that presentation. So let me go on and introduce Dr. Skinner. John Skinner is also someone who I met very early in my career. I met him when I was a graduate student at Stanford, and he was a visiting professor there. At the time, he was at University of Virginia, and he was already had an excellent reputation as a top scholar in the field of public finance. So when you see him up here, he may look familiar to you because he was one of the two participants in a debate featured by Fortune magazine just last year on whether we're saving enough adequately for retirement. And so looking at public finance, soon after I left graduate school, I think, you moved up to Dartmouth College. And once John took a position at Dartmouth, there was a strange thing that happened, because up at Dartmouth, a strange thing but also pretty neat actually, up at Dartmouth there's a group led by Dr. John Wenberg, which looks at practice variations in medical care. And I think if you've come to our Baker Institute events, you've seen me mention their group before. They publish the Dartmouth Atlas, and you can look at their work at the dartmouthatlas.org. And what happened is John just went and contributed a whole nother field of insight into looking at these medical practice variations, and combined it and folded in all a number of different economic insights. And so now a good part of his research is focused on public finance, but another part of it is actually looking at variations in medical care across the United States and what those can tell us about finding the most efficient and high-quality methods, the most cost-effective methods of delivering health care. And so with that, I'll hand things over to John.
Wonderful introduction. I want to start, I'm inspired by Karen showing her collaborators, and this is sort of a normal day at work at Dartmouth. And that up in the corner there is Jack Wenberg, who's the kind of the godfather of all of this group. There's a number of people, actually Lauren Baker's there, Elliot Fisher, Amitabh Chandra. And anyway, we try to have fun up there. But you're right, I sort of went up to the northern woods and started looking at maps, and I always liked maps as kids, so I've continued with that. So in this talk, Karen is a tough act to follow because I think everything she says is very sensible. It's backed by a lot of research, and I agree with it. And I think ultimately I'm going to come back to where I'll end up in this talk is sort of where she ended up as well. But I'm going to take a slightly more cranky view, and I'm going to focus on costs, less on quality, less on expanding the uninsured, but on what do we do about healthcare costs. So that's sort of my spin on this problem. And it's not hard to find these kinds of graphs. This is for Medicare expected total expenditures. You see, we're doing okay now. We've still got the revenue to cover things, but payroll taxes flatten out. I guess I can look at the premiums kind of grow, general revenue go up, but basically total expenditures just take off and never look back. And a lot of that is, in fact, almost all of it is, you could call it technology. It's just sort of cost growth per person. It's not just the aging of the baby boomers. And so that's a really tough problem. As Doug Holtz-Eakin, who's coming, I guess, later to speak, once said Social Security is Grenada. Medicare is Vietnam. And I think that's sort of the way I think about this is a really, really hard problem and something I'm still trying to learn about. Now, healthcare cost growth is a really serious problem for states' efforts to expand the coverage to the uninsured. Massachusetts is struggling with much higher than expected costs in its connector board, and at least according to the Wall Street Journal, that the costs, and by inference cost growth over the last decade or so, was instrumental in bringing down efforts to expand insurance coverage in other states as well. And so, I do believe that covering the entire population is incredibly important, but I think it's always going to run into this problem of cost growth. And in particular, even if we did manage to cover everybody, say in 2009 or 2010, by 2012 or 2013, continued cost growth of 5 or 6% or 7% would start to unravel the entire budget, because ultimately, the government is just going to be running short on money. Now, I looked at some of the candidates' statements on healthcare costs, and they were fairly vague. Nobody wants to talk about how we're going to have to do something about cost growth. But I think that John McCain did make a pretty clear statement. Bringing costs under control is the only way to stop the erosion of affordable health insurance, save Medicare and Medicaid, protect private health benefits for retirees, and allow our companies to effectively compete around the world. Well, that kind of pretty much says it. So I think that's kind of one reason why I'm really focusing here on healthcare costs and really doing something about costs. Now, the Democrats have some quite detailed goals, and in particular, I thought Hillary Clinton was actually more specific about the changes she would make, and it almost sounded like Karen was advising Mrs. Clinton. There were prevention, information technology, better coordination of care, and she actually mentioned this idea of medical homes, which I think is an excellent idea, and insurance reform. And I think that they do have the potential to save some money, but I'm not convinced that just doing these things on their own will that you could count on a lot of savings. Again, this is where I'm sort of being skeptical here. And I think there's some other possible reforms, again, drug price controls and malpractice reform, which I think, again, are very important and are things that something should be done about. But, again, I don't see these as – this is the skeptical part. I don't see these as fundamentally sort of shifting the growth path of healthcare costs in the future. And so this has also gotten me kind of more interested in thinking about the pathophysiology of cost growth. Why is it growing? Why is it growing more in some areas than others? And okay, so that brings me to my favorite map. This is Medicare spending in the United States, and it's adjusted for the age and sex and race composition of the region. And it ranges tremendously from, in this case, this is somewhat older data, 2003, but from about $4,300 per capita for people over age 65 up to $11,300. That's Miami. Miami is now $15,000, $16,000 per person. And in fact, if you think about what we like to think of as the opportunity cost of all of this spending, that if you take the lifetime expected Medicare expenditures of someone who lives in Los Angeles versus someone in Minneapolis, it comes to not a new Ferrari, but a used Ferrari, about $125,000, although my Italian friends tell me that no self-respecting Italian would ever drive in a yellow Ferrari. It's always got to be red. So these are really big numbers, and the question is, the question as economists that we might ask is, if you could make the comparables and adjust for all the kind of differences between Los Angeles and Minneapolis, maybe it wouldn't be a Ferrari, but it might be a Lexus. Would people in Los Angeles be willing to take the Lexus and Minneapolis-style health care rather than the kind of health care that they get now? So that's sort of the fundamental question we're trying to think about. What's the value of all of this spending? Now, you might think that people in Los Angeles are getting a great benefit because they're getting all of this health care and that's got to be good. But in fact, and this is again based on some earlier study by Kate Baker and Amitabh Chandra, that in fact there doesn't seem to be a positive correlation between spending and quality of care. In fact, based on a study by Steve Jenks in JAMA in 2003, where he and his co-authors ranked the quality of states, you can see that there's actually a negative correlation. I'm sorry to say that, I guess like Karen's table, that Texas ends up being pretty close to the bottom. Actually, they're quite close, I think, to your rankings. Because you've got kind of New England up on top and Texas and Mississippi on the bottom. So again, the question is, well, where's all of this money going? Why is there so much spending in some areas than another? And let me suggest two kind of general reasons. The first is that physicians and other healthcare providers differ dramatically in their medical opinions about what works and what doesn't. And also, I have to insert this, their entrepreneurial efforts. And you'll see what I'm talking about in just a minute. And sort of the best example is rates of stents, that is, or angioplasty, per 1,000 population in the general population. This is not really so much for heart attacks. Heart attacks are a very small fraction of these folks, but it's for either stable or unstable angina, or a variety of cardiovascular conditions which may or may not require stenting. And you can see that there's a lot of difference in professional opinion about what's the right number of stents in a particular community. I mean, you can say that Pueblo, Colorado, which rates of under 5 is probably a little bit healthier than, say, Lafayette, Louisiana, but I should mention Lafayette's the second highest in the country, and they're actually they were under investigation at this time by the FBI for fraudulent stents, so those rates may be a little bit high, and you can see Houston is about in the middle. It's near the mean, but the interesting place is Elyria, Ohio, which is not a particularly sick part of Ohio, and the rate is I mean, this is the highest anywhere, and in fact there's a photograph of one of the interventional cardiologists that does these procedures. This was on the front page of the New York Times when we fed the data to the New York Times writer. And in particular, I went out and visited my uncle who used to teach at Oberlin College, and I said, oh, you're kind of close to Elyria, and he said, yeah. He said, I got 2 of them. So you know, these physicians they're not doing anything illegal, but they basically have this view that if you get stents in quick and you do it before they really need it, that this is really good for their health. So there's a wide variety of sort of physician beliefs. This is something Jack Wenberg has been preaching for years, and I'm only gradually beginning to realize, yeah, that's probably true. But what do you do about this? I mean, you can't really address this in technology assessment issues, because you know it's not so much are you using stents or not, but when do you use them? For which patients? Do the patients even want them or not? Or do you tell them, look, you're a ticking time bomb and we got to get those stents in, or else you'll never make it home. So those issues, I think, are critical to be addressed both from the patient's point of view and from the fiscal point of view in any kind of reform. The second problem, and again Karen touched on this, is that Medicare pays more for doing more. That's the way it's set up. It doesn't pay you if you happen to save money by not doing an unnecessary procedure. And again, I think we're in this kind of gray area where there are sometimes things don't always port from one computer to another. Where there are institutions that are more than happy to help you set up screening CAT scans, MRIs, and so forth as a practicing physician in your own office. And you know, physicians, they're getting how much they get paid cut, so the price goes down. So there's a lot of pressure to kind of keep volume up. And so this kind of plays right into oh my goodness, look at that. Okay, it plays right into this. This is you know, sit back and relax here, because we have, this comes from a brochure of a company that provides these CAT scans. And what you can do is you look at the table and you say, well, if I do 1.8 procedures a day, I break even. But if I do 10 procedures a day, I make $36,000 a month on this per machine. And it's like, that's a tough one to resist. The incentives are definitely pushing you towards doing more. And I think somehow we have to do that, as I'll talk about later on. We don't want to go in the other direction and get back into this HMO problem of, you know, oh, they're not doing things for me because it costs too much. But somehow we have to deal with that problem. I should mention that this is a, let's see, there we go. Okay. This is an email that was sent to Elliot Fisher. These marketing ploys are wildly successful across the entire country. Patients are viewed as the ball in a pinball machine, popping back and forth, ringing up profits until finally they escape past the paddles and can no longer render income. It's kind of a scary thought. And I think, again, this is not something that you know, I'm not saying that, you know, that there are players in this system that are somehow harming patients in any sense at all. But it's when you set up a system like this, when the incentives are set up in this way, it's sort of like you get what you design your incentives for. And so it's not too surprising to me to see this. Well, I want to talk a little bit about two cities, and actually I'd welcome your comments afterwards, El Paso and McAllen, because they each experience quite different growth rates. And I'm kind of trying to figure out why. So here's data from 1992 to 2005. This is per capita, age, race, sex-adjusted healthcare expenses. The dotted line is the U.S. average. So El Paso started a little bit below. It kind of rose up, and it's now back below. So it's grown at about the same growth rate as the U.S. average. McAllen is quite different. In fact, they started out to be very similar in 1992. But for whatever reason, its spending has gone up a lot there. It may have something to do with building hospitals, but the point I'm trying to make here is that Medicare is paying for this, and it's not asking why. Medicare basically pays the bills, and it's only when some, you know, people up in the woods in Dartmouth start looking at the data that they say, wow, look at this. McAllen is almost twice as much per capita as El Paso. I'm not sure why. They're both border towns. They have fairly similar education proportions. The average wages are quite similar as well, so I'm not sure why. But just to kind of give you an idea of sort of what's accounting for the growth, it's pretty much across the board. Here we are in 1992. They look pretty similar. And here we are in 2005. A big growth here in home health care, which was a growth industry in Houston as well, but dropped down after 97. But it apparently in McAllen it's come back quite dramatically. So that's the highest in the country, by the way, for home health care by far. Spending. It's about $2,500 per person, not per person who's getting home health care, per person, person 65 and over. So there's our topic for discussion. If anybody can help me, that would be great, because I can't figure it out. Now, you'll be happy to see that Houston is actually pretty much tracking the U.S. average. It looked like there was a little bit of investment in home health care centers that was shut down by the 97 Balanced Budget Act. But again, there's nothing, just to reassure you, there's nothing out of the ordinary here. Now, the point that economists often make is that you know, small changes in growth rates can have huge effects over the long term in levels. And so I kind of did this little scenario where turns out in 2017 predicted healthcare expenditures are about $4.3 trillion. I guess you had $4.4 trillion. And if you went back and you said, well, in 1992, let's grow the entire country at the rate that McAllen was growing, has been growing over the time, and continue it off in the future, that's about 7.5% per capita. We'd be spending $11 trillion. And if we picked another area, Salem, Oregon, we would have reached $2.8 trillion, which is actually quite reasonable considering we're spending a little over $2 trillion right now. And the point here is that again, I think we can do something about growth. It's feasible, and using the logic of the previous talk, that let's look at places that we're able to do to achieve low-cost growth and see if we can somehow emulate those regions in other parts of the country. I think that's the strategy. So it's kind of reassuring, first of all, that there seems to be a lot of savings that can be obtained in the U.S. healthcare system, and second, that some regions of the country seem to do a pretty good job of being low-cost health providers, and we should pay more attention to them and perhaps even reward them for the fact that they've saved so much money. Now, I was fascinated by this statement, again, from the John McCain website. Controlling healthcare costs will take fundamental change. Nothing short of complete reform of the culture of our health system in the way we pay for it will suffice. Well, I'm not sure that I actually saw the fundamental reform in his proposals, as we saw before. But I think it's remarkable that he would kind of step out and say that, because so few of the other candidates are saying very much about cost. It's a dangerous thing to talk about, because if you try to lower costs, there's often, to us it's a cost, but to somebody else it's income. And so if you're lowering costs of healthcare, you're also reducing somebody's income. And they usually don't like to hear that, especially in an election year. But I think that he is quite unusual in kind of stepping forward and saying, oh, well, we really do have to do something about costs, which I quite agree with. So I'd say, again, general principles for any reform is, and this is following up on the earlier talk, incentives should reward value for each dollar spent. And efficiency, not in the sense of physicians, for whom efficiency means bill as much as you can in a day, but efficiency in the sense of every dollar that's spent gives you good value to the patient. And the second is that I think we need to measure quality in a much deeper way than we have in the past. Doing eye examinations for diabetics is fine, but I actually haven't looked, but you could imagine certainly El Paso and McAllen being quite similar on those sort of standard quality measures, while one is spending twice as much on health care as the other. And so I think you have to sort of, we need to develop measures of quality that really get at whether all of this extra spending in a city like McAllen is actually providing value to the patient. I'm a little bit suspicious, but you do want to answer that question. Now, one proposal that's being suggested by, and here I rely a great deal on Elliot Fisher and his work, is the idea of creating these accountable care organizations. They're a little bit like medical homes in the sense that they're designed to provide a continuum of care, but on the cost side, they have to be big enough so that statistically you can measure quality. If it's just one practice, one person practicing, you can never really figure out whether they're doing a better job or whether they happen to be unlucky and one of their patients died. You need enough people so you can get statistical precision in judging whether these groups of physicians are providing good quality or inadequate quality. And you also want to have these groups that are able to implement priorities and budgets. They're able to somehow have a meeting and say, look, we've got to slow down on some of this high-cost MRIs because it's costing us a lot of money in terms of the reimbursements from insurance companies or Medicare. And the competition, the role of competition, I think, comes in terms of these different groups competing among each other in the way that the federal system works, where they are trying to attract patients into their network in large enough regions where they can actually compete. And my role model here is Southwest Airlines. I mean, they get the job done. There's no frills. It's cheap. It's efficient. Wouldn't it be nice to have kind of a Southwest Airlines of healthcare? And the concern would be, well, gee, but maybe you'll get sort of the inadequate quality. There's no if there's no agency kind of keeping track of things. But this is where quality measures are really critical, because if you can measure quality reliably, you can also make sure that these firms that these ACOs are not doing a bad job. And this is what we want to avoid. Is you may remember, let me think, when was Puffy popular? That was about 1999. So this sense that the insurance companies or that the provider groups are saving money or making money at the expense of patients. And again, I think that's a real problem if we're going to try to actually save money. And the only thing you can really hope for is better risk adjustment, so you can pay these groups to accept high-cost patients, and better measurement of quality. And there I have to be optimistic, because otherwise we're stuck. And also ask the patients whether they're happy with their care. You could imagine a system where they're reimbursed on the basis of not just the standard quality measures, but also patient satisfaction. And this is, again, something that's coming along as well. So now I'll finish up with kind of an open question. Well, suppose these approaches don't save money, and that's the goal that you're trying to do, then what? And that's what I'm not entirely sure about, and would welcome comments. So that's it.
Well, thanks, John, for another set of excellent insights and for presenting us with a puzzle. I love puzzles. Maybe one of the members of the audience can answer that. If I could ask both Dr. Davis and Dr. Skinner to take seats up here. And I held both of the speakers, I told them strictly that I would hold them to the 20-minute time limit, because I've learned from past experience that there are a number of people who have excellent questions in the audience, and we benefited a great deal from that discussion. So now we're open for comments and questions. So there are 2 microphones, and please, Dr. Traber.
Thank you, Dr. Ho, for putting together a really fine program. I have a question, comment, and then a question to ask you to think about, maybe comment on. One of the issues with projections is that they take life as we know it now and project it into the future. And it can't really take into account innovations that may dramatically change things. I think if we were in the 1940s and we were projecting healthcare costs into the future, poliomyelitis would have been a major part of our healthcare costs in 80 years hence. Might even be $2 trillion on its own. But in fact, we're paying a couple of cents for polio vaccine for children. So I think that the projections into the future that can't take into account innovation are very challenging. So my question is, and something that I don't see spoken about in the discussions, is that the real cure for healthcare costs are innovations that bring value and really change the paradigm of what healthcare costs. And research and development is the fundamentals of innovation. And we really need to see in the debate how research and development is going to be funded and brought into innovation. So I just wonder about your, if you would comment about that in kind of healthcare reform policy.
Well, I think you're absolutely right. It's why we called our report Bending the Curve. I mean, we can't just continue on that same line. We've got to change things, and I think innovation is the way to change things. And partly it's investment in research, and some of that could be a cure for cancer, a cure for Alzheimer's, that would certainly make a difference in those paths. It can be investment in health systems. Jonathan raised a lot of questions that we don't know answers to, so trying to find out why costs are low and quality is high in certain places and try to spread those best practices. But I would say there are kind of 2 camps. One that believes you will get innovation if you change the financial incentives for healthcare providers, for doctors, for hospitals. Basically what Jonathan is talking about is converting the health system into competing Southwest Airlines. So you can get your complete care from this place or your complete care from that place, and you know what their quality records are, their mortality, survival rates, and their total costs, and you can pick on the basis of that. So you change the price signals in the market. The other camp believes in basically having people pay out of pocket. If people didn't have so much insurance, if they had high deductible health plans, consumer-driven health plans, if they were, instead of getting insurance from their employer, they were buying it on their own, if they had skin in the game, then they would really have a financial incentive to seek out the best deal. And that's the way that we would force innovation. So kind of two camps. You heard, I think, both Jonathan and myself talking a lot about changing the price signals that face doctors and hospitals, and less what was tried in the last 8 years of trying to increase the amount that patients pay and giving them an incentive to shop for cheaper care.
That's right. I guess in thinking about what I see as the next cost-saving innovations, I think it will be in the technology of actually providing clinical care, of taking the vast amount of knowledge that we know that is out there in the world now, and with 10,000 randomized trials coming along every year, it's impossible for any one person to keep up with all of these things. And thinking about technological innovations to improve the quality of care and to reduce costs, because there are groups that, I mean, some of the Dartmouth Atlas numbers suggest that, for example, the Intermountain group treats patients in the last 2 years of life, and these are all pretty sick patients. They all die at the end of 2 years for about $25,000 a year, whereas other hospitals are spending $90,000 a year and probably getting worse care. I think that is a tremendous potential for technological improvement. I don't see innovations that, at least when I read about sort of new medical innovations, I don't see things which actually save money. There have been some, but they tended to end up with other innovations which cost a lot. For example, there's new ideas of sort of customizing cancer drugs to an individual's DNA that has tremendous clinical potential, but it's also extremely expensive if you think about bringing, basically doing DNA scans on everybody and trying to match them up with the best kind of drug. That's not going to save money. It will improve quality, but it won't save money.
I want to just comment on that, and somehow we have to get into the equations, the changes in life expectancy and quality of life and so forth. I mean, the life expectancy at the turn of the last century was 46 years, and now it's approaching 80, and we have people working into their 80s and so forth. So somehow we have to think about how that plays into the value equation. And I know economists work on that. I haven't seen a good evaluation of that.
I think you're absolutely right to say let's don't just focus on cost, let's focus on what we're getting, value, and that's quality and outcomes. But we fund a number of international studies, and one that just came out recently found that the U.S. is 19th out of 19 countries on mortality amenable to medical care. And furthermore, over the last 5 years, we've slipped. We were 15th out of 19. And the truth of the matter is our mortality went down from 115 deaths per 100,000 to 105 deaths per 100,000. It's just all the other countries were improving at a faster rate. So we spend twice per capita what other countries spend on health care. We're 19th out of 19 on mortality amenable to medical care. So we can't just be complacent and say we're got the best health system in the world, getting a lot for what we spend. We've got to learn from countries like Denmark that really have diffused information technology, like the Netherlands, that really has public information on quality and cost.
Well, while this gentleman is coming up to the microphone, I'll just ask another question. Both of you talked about changing financial incentives to achieve higher quality health care. If the next president comes in and wants to reform and change the reimbursement systems under Medicare and Medicaid and whatever extent they can affect the other policies, Do we have the knowledge to be able to do that immediately? I'm just wondering if we even have the scientific knowledge to be able to say, well, how should we do this? Well, if we want to get physicians to lower, to treat hypertension, do we know exactly what incentives do work? Should we do it at the level of hypertension? Should we do it at the level of overall satisfaction of care for the patient?
You know, I think we're health services researchers, so we think that there needs to be more research, even though we fund a fair amount of that research. So no, do we know the optimal, but do we know enough to get started? I think so. I'm on the one conflict of interest. I'm on the board of the Geisinger Health System in Pennsylvania, and it offered a surgical package for coronary bypass with a 90-day warranty, and they actually used that phrase. And they said for a certain price, it will cover all your bills, your hospital bills, your doctor's bills, anesthesia, and anything you need for 90 days for a flat fee. And that is so different from what we have now, where if you have a complication in surgery, you need to go back in with an infection, or you need to go back and have the surgery done over, you pay again, or Medicare pays again. So moving toward what I think of as a global fee for a surgical procedure is something. As I mentioned, Bridges to Excellence, this coalition of the major corporations, have enough data that they say if you excel at diabetes or cardiac care or spine care and meet the standards of a patient-centered medical home, we will give you an extra $125 a patient a year, because we know that those kinds of settings have lower ER use, lower hospitalizations, and so it's better for the patient, it's better for the physician that can get up to $100,000 more in his or her practice, and it's better for the insurance company in that they're saving money by spending less on emergency rooms and hospital care.
I'm Dr. Leeds. I'm a gynecologist, and I guess my golden years of practice. It seems to me, as you give your figures, I didn't see a division between preventative care and treatment. And to give you an example, I happen to be interested in osteoporosis. And we spent $18 billion on complications of osteoporosis approximately 4 years ago. It's predicted that it'll be $25 billion in 2025, yet we're cutting down reimbursements for bone mineral density to the point where doctors really can't afford to do this. Then you're going to have higher costs and not put them toward treatment rather than put more cost to preventive medicine and avoid the high costs of treatment. I'd be interested in hearing your opinions on that.
No, I entirely agree. I think when the federal government or state governments think about cost cutting, the way that they do it is they cut the price. And that's generally exactly the wrong thing to do, because it encourages some doctors to do more of at least the high-paying procedures, and it punishes the doctors who are doing a good job in trying to use preventive care, which often does not pay as well. And so I think that's the sort of idea of moving towards a system where you don't pay for what you try to basically provide enough money to provide those preventive services, and you get rewarded if you do that. And in some cases, you might be penalized if you have enough patients coming in 10 years later with osteoporosis. But again, that's why I'm saying that the quality measures are the quality issue. Measuring quality gets really difficult, because if you find that some physicians are not using preventive care and that their patients are getting sicker, it's really hard to figure out whether it was because of the physician or because they were sicker to begin with.
And I would just agree with you that we need to encourage preventive care for osteoporosis, and bone density tests are one way of doing it. But I'm just amused that as a patient, at one time in my professional life, I have had a physician talk to me about calcium. So physicians aren't paid for counseling about diet. They might get paid for doing a bone density. But can you imagine never ever mentioning to a woman or asking her how much calcium she has in her diet and talking about how important that is and what the severe, and you've seen it in your practice, the severe ramifications are of osteoporosis if women do not get adequate calcium in their diet.
I think that osteoporosis has come to the forefront, and more and more physicians are talking about vitamin D, which is a gross loss in this country with very low vitamin D, and calcium supplementation. So I think that is gradually improving as more people become aware of osteoporosis, and they're asking their physicians about that. Thank you.
Hi, I'm Louis Foxall with MD Anderson Cancer Center, also chair of our Harris County Healthcare Alliance. I appreciate all your work, and your research is tremendous, very enlightening for us in these areas. And all of it obviously is directed at the national level and the high level view of our policy challenges. But and I assume eventually we'll have a new president elected. Even so, there seem to be some who are concerned that there may still be an inability to enact change at the federal level, and that we may still be forced to deal with this at a state or regional level. So if you were made governor of Texas and given ultimate power to enact one change to improve the quality and reduce cost of our healthcare system, what would it be?
Well, since I personally think the biggest problem that Texas has is the high rate of uninsured. So if I could only do one thing, I would start with children and make sure that all low-income children were covered and put the money into the state children's health insurance program. But I would go beyond that and require every family to sign up with a medical home and hold that medical home accountable for making sure that child is getting all the appropriate preventive care, that they are getting developmental services, so you're finding out if there's a behavioral or a developmental problem early on, getting that referred and dealt with so that when that child's ready for school, that child's ready to learn. So I would invest in young people, and it's relatively low cost. So I hope you're not right that we continue to have gridlock at the federal level, but I think that would be the priority for me if I were governor of Texas. And I'm not running. I'm not an advisor to Senator Clinton. I'm not a political type, but we stay nonpartisan and neutral on these issues.
If I could just add to that, in other countries they actually have programs for example, the Progresa program in Mexico, in which part of the condition of receiving financial payments to low-income families is that you have to bring your children, you have to show that your children are in school, that they're getting immunizations, that they're doing all of these sort of positive, healthy things. And in fact, I just saw my colleague Jonathan Zinman just finished a paper looking at smoking cessation efforts in the Philippines, which were extremely successful, and were in the way that they tested them. They committed money, which they got back if they were shown to be tobacco-free after 6 months, and they did this by giving people urine tests. And so there are a variety of ways, I think, to kind of line up incentives, transfer payments with good health behaviors for your children, which I don't think have been explored as much in the United States as they've been explored in other countries.
We have time for this question and one more question. And since we're at Rice, I would really love it if the last question came from a student. I see you all lurking back up there, so don't be shy and intimidated by this audience. I know you have good questions.
Hello, my name is Mike Gillum, and I was curious about the role of disseminating best practices through health information technology and your thoughts on that, particularly in systems differing in utilization, if any thoughts on that as far as the dissemination of best practices utilizing IT.
Senator Clinton would establish an institute on best practices. Senator Obama goes further than the other candidates by committing $10 billion a year to invest in IT. So both of them have fairly developed plans on both identifying and spreading best practices and accelerating the diffusion of information technology. But we have an infrastructure in this country called the Quality Improvement Organization. So Medicare pays $300 million a year for these organizations to work with hospitals and physicians in improving quality of care. But I think the mandate, I was on an Institute of Medicine committee that evaluated that program, and it needs to be focused on quality improvement. It has some other functions. It needs to be adequately funded. And the mandate means to improve care for everybody, not just for Medicare beneficiaries. So I would use that. It's, I grew up in Oklahoma, and we had the Agricultural Extension Service right there in your county advising you about the latest techniques and best practices. And I think applying that to the health system by using these quality improvement organizations that exist in every state, but really focusing them on that issue. And but to do it, you just have to have better information. You have to know, and that's why our commission is really focused on identifying the benchmarks. We're posting loads of case studies on our website of who is the best, whether it's cancer care, diabetes care, care of young children, so that then we can get those stories, find out how they do it, and others, I think, eagerly adopt it, because I think what we have in the healthcare field is professionalism and a commitment to being the best. And it's a matter of seeing what's possible, who's doing it, how they're doing it, getting some technical assistance about how to do that, and some financial support with the tools, which are often information technology.
Hi. Thank you for coming. This is for both Dr. Davis and Dr. Skinner. I think we can all agree that there has been overall a lack of leadership on a national level regarding healthcare in the past few years. But we have seen many initiatives on the state level to improve different things. We've seen tobacco cessation, different insurance plans, collaborative initiatives. And I was wondering, from all your research and all the work you have done looking at the states, are there any programs or initiatives that have been shown to work that could be implemented on a national level, that should be implemented on a national level?
Well, I'll let Jonathan maybe try Vermont and chronic disease. But what's interesting about this state scorecard, again, I come from Oklahoma, is that Iowa was number 2. Hawaii, truthfully, is number 1. We'll set that aside. But Iowa was number 2, and Oklahoma was 50th. And I think, well, they're not that far apart. What is Iowa doing? And some of it is a tradition of more collaborative approaches to care. They actually cooperate, get along, try to learn from each other, help each other, try to figure out what's better, and work together to try to pull that off. Obviously, state government has been a leader. We've actually funded projects to improve child development screening, and Iowa has participated in those. And Governor Wilsack, when he was governor of Iowa, committed additional funding to make sure that all children are screened and these kinds of issues are identified early on. They've got an excellent children's health insurance program. So you can look across these states and typically find things. We took our commission to North Dakota, and fascinating how with very little money, they are one of the top quartile states on our performance scorecard. And they've got pharmacy techs working in hospitals or in retail clinics with a pharmacist 100 miles away, linked by a screen, so they can look at the prescription before the pharmacy tech dispenses it. But they use nurse practitioners, physician assistants, pharmacy techs in innovative ways to be able to get care to people using telemedicine to meet quality standards. So, mother's the necessity is the mother of invention when they need it, because they simply don't have the professionals to render the care. They've found some very high quality, low cost ways of providing that care.
Yeah, no, I'm actually not an expert on the Vermont system, but I mean, just to sort of reiterate what was mentioned before, I think Massachusetts is taking the lead on coming up with a connector board of basically making the statement, we will insure everybody in the state. I think that was a really important thing to do. I have to tell, this is sort of a personal story. My father was very sick, and he was kind of going in and out of delirium, and I was talking to his doctor about whether Massachusetts should enact this statewide change, and I was trying to make the point that it's better for the federal government to actually step in, because if a state does something that involves higher taxes or some kind of onerous requirements for businesses, that the businesses can just move across to a different state, which kind of restricts the ability of states to do things. And my father came out of his delirium, and he said, well, slavery was repealed state by state. And in fact, he doesn't remember saying that, but I thought that is a really important thing when we think about the importance of statewide initiatives. Sometimes you can't wait for the federal government to do things, that you need the states to take the lead.
Well, I'd like to thank both Karen and John for some very valuable food for thought, both for next Tuesday and for beyond that. And thank you for taking time out of your busy schedules to come here and speak with us. We will have this information posted on the website and the entire session, and we look forward to seeing you again. Thanks very much.
I'm glad you were here to answer those questions.
I felt like I wasn't giving you equal time.
No, I was